بسم الله الرحمن الرحيم. السلام عليكم طلبتنا الأعزاء، رمضان كريم عليكم وعلى عوائلكم، تقبل الله طاعتكم والحمد لله على سلامة الجميع وكفاكم الله شر الداء والوباء. طلبتي الأعزاء، خلال 5 محاضرات الجاية إن شاء الله we will discuss the cardiac diseases in the childhood. 2 lectures will be, in the first 2 lectures we will try to concentrate about the congenital heart disease, both cyanotic and acyanotic, with discussion of the most common types of it, and 1 lecture about the subacute bacterial endocarditis, 1 lecture about the rheumatic heart disease, and 1 lecture about the congestive heart failure. Before we are entering to the discussion, the congenital heart disease, you must know the fetal circulation and how the fetus it is transported from the intrauterine to the extrauterine life, because this period it is very critical for determination of the onset and severity of the most of the congenital heart disease. In the fetus, the placenta is responsible for the gas exchange, which acts as an artificial lung. While the lungs are functionless, they are shrinked and filled by the fluid, and pulmonary vessels are vasoconstricting, which is resulting in the increase the pulmonary vascular resistance much higher than systemic vascular resistance, resulting in the shifting of the blood away from the pulmonary circulation. As you know, the cardiac output in the newborn infant and the adult, the right ventricle and left ventricular outputs, they are goes in series. That means the deoxygenated blood from the body, it drained by the superior vena cava and inferior vena cava to the right atrium, which goes through the tricuspid valve to the right ventricle, then through the pulmonary artery to the lungs, where the gas exchange is done and blood become oxygenated, back to the heart through the pulmonary veins to the left atrium, and then through the tricuspid valve to the left ventricle, and then from the left ventricle to the aorta, where it will be goes to the upper and lower part of the body. This is the newborn and adult cardiac output. While in the neonate, in the fetus, the right and left ventricles are present in the parallel circuit. That means both the right ventricular output and left ventricular output, they are goes separately without any connection between the 2 circuits. While in the adult and newborn, as I said, it goes in the series. How this done? In the fetus, there are 3 important structures for this parallel circulation, which are ductus venosus, foramen ovale, and ductus arteriosus. This is figure to explain to you how this fetal circulation is occurred. This is the placenta, where the oxygenated blood, this is the red blood, enter to the fetus through the umbilical vein. Through the umbilical vein. Then from the umbilical vein, approximately of its blood, about 50%, approximately 50% of it will be entered to the hepatic circulation. Enter to the hepatic circulation, and the rest 50% will join to the inferior vena cava through the ductus venosus. Where it will be mixed with the poorly oxygenated blood from the lower part of the body. This combined blood of the inferior vena cava, it will be entered to the right atrium. Enter to the right atrium. From the right atrium, it will be shifted directly to the left atrium, not to the right ventricle, no, through the left atrium through structure which is called the tricuspid, Eustachian valve. Through the structure which is called Eustachian valve, which is a flap of the tissue located at the junction of the inferior vena cava to the right atrium, which is directed the blood through the foramen ovale to the left atrium. From the left atrium, the blood it will be goes to the through the mitral valve, when then it is will be ejected into the ascending aorta. Sorry, it will be ejected to ascending aorta to supply mainly the fetal upper body part and the brain. From the ascending aorta, where it will be supplied the fetal upper part and brain. This is the right. This is the left ventricular output. Fetal superior vena cava blood, which is drained from the upper part of the body, it will be entered into the right atrium. Then through the tricuspid valve, it will be goes to the right ventricle. Then it will be ejected through the pulmonary arteries. Then it will be ejected through the pulmonary arteries. Because the pulmonary circulation, as I said, it is vasoconstricted and the lung is filled by the fluid, so the pulmonary vascular resistance, it is higher than the systemic vascular resistance. So the blood will be shifted through the ductus arteriosus, which is combined the descending aorta and pulmonary artery, which is lead to the what we call right to left shunt, right to the left shunt. So the blood it is goes mainly 95% of it will be goes through the ductus arteriosus to the descending aorta, and only 5% of the blood from the right ventricle it will be goes to the lung. From the descending aorta, it will be supplied the upper part, the lower part of the body, and the blood will be returned back to the placenta through two umbilical arteries. The blood from the lower part of the body, it will be goes to the return back to the placenta through these two umbilical arteries. At birth, what are changes are occurring? This is in the intrauterine life. At birth, because of the rapid expansion of the lung and an increase in the arterial VO2 lead to the rapid decrease in the pulmonary vascular resistance and to become much lower than systemic vascular resistance. This is the first change. Other change, because of the clamping of the umbilical cord after delivery, so it will be there is a closure of the umbilical arteries and vein. This will be result in the much increase in the systemic vascular resistance more than pulmonary vascular resistance, and this will be result in the closure of the ductus venosus. Will be result in the closure of the ductus venosus. So the blood, these changes will be lead to the blood will shift from the left to right through the ductus arteriosus. Because of the very high pulmonary vascular resistance, only 5% of the right atrium, right ventricular output, it will be goes to the lung, and 95% it is goes through the ductus arteriosus to the descending aorta. Now, because of the much decrease in the pulmonary vascular resistance, now the most of the all of the pulmonary, the right ventricular output, it will be goes to the lung, and this results in the functional closure of the ductus arteriosus. And it will be changed over several days to form ligamentum arteriosum. And now the entire right ventricular output will be flow into the pulmonary circulation. Other change, it will be occur that increase in the volume of the pulmonary. هنا بنصار the entire right ventricular output, it is all goes to the blood. So the pulmonary circulation, it will be much increased, and this will be result in the increased amount of the blood which is retained through the pulmonary veins to the right, to the left atrium. And now the volume and the pressure in the left atrium, it will be become much higher than the right atrium. This results in the pressure gradient difference between the two atria and result in the functional closure of the foramen oval, although it is remain potent until the adult life. This is the fetal circulation and how the transition from the fetal to the newborn circulation. It is very important because if the ductus arteriosus remain open and not closed, this will be a result in the congenital heart disease. And the pulmonary vascular resistance, which is much higher in the fetus life than in the systemic vascular resistance, it will be remain high in the neonatal period, and there is a gradual decrease in the pulmonary vascular resistance after delivery, and will be reached to the nadir level of the pulmonary vascular resistance in about 4 to 6 months in the full-term neonate. And this is the critical time for the presentation of the most of the congenital heart diseases, as we see in the next lecture. Now I will enter to the classification of the congenital heart diseases. The heart diseases mainly classified into the acyanotic congenital heart disease or cyanotic congenital heart diseases. Acyanotic congenital heart diseases, it is also subclassified into the two groups. The first group, it is acyanotic congenital heart disease causing increased volume load. These are include arterial septal defect, يعني معناها شنو increased volume load on the heart. These are including arterial septal defect, ventricular septal defect, arterioventricular septal defect, نسميه AV canal أو Cushing defect, and patent ductus arteriosus. Pathophysiology of this group, there is presence of the communication between the two circulation, I mean pulmonary and systemic circulation, causing left to right shunt. And this result in the shifting of the oxygenated blood back to the lungs, which is mean left to right shunt, and it is will be increase the pulmonary blood flow, which is resulting in the increased cardiac output and manifestations. Second group of the acyanotic congenital heart disease, including the group which cause increase in the pressure load. The first group, we said it cause increase in the volume load. The second group, it will be cause the acyanotic congenital heart disease with increased pressure loads. These include valvular pulmonary stenosis, valvular aortic stenosis, coarctation of the aorta, tricuspid stenosis, mitral stenosis, and pulmonary veins obstructions. Pathophysiology of this group, there is a presence of the obstruction to the normal blood flow, which is either obstruction to the ventricular outflow. Ventricular outflow is يعني وين ventricular outflow؟ أما aortic stenosis أو pulmonary stenosis, which is more common and it is occurs in the first three causes اللي قلنا هن valvular pulmonary stenosis, valvular aortic stenosis, or coarctation of the aorta. There is obstruction either in the pulmonary artery or in the aorta. Okay, or there is coarctation of the aorta. The second group, obstruction to the ventricular inflow. Ventricular inflow, يعني the blood من اللي يدخل from the artery to the ventricle, there is obstruction, which is more common, which is less common than the obstruction in the ventricular outflow, and it is occur in the other three causes اللي هن tricuspid stenosis, mitral stenosis, and pulmonary vein obstruction. طبعا pathophysiology of this. Okay, sorry. Second group, cyanotic congenital heart disease. هسه قلنا cyanotic congenital heart disease either with cyanotic congenital heart disease with causing increased volume load, or those which are increased pressure load. Now, cyanotic congenital heart disease, it is also subclassified to two groups. Cyanotic congenital heart disease with decreased pulmonary blood flow. These include tetralogy of Fallot, pulmonary atresia with intact septum, tricuspid atresia, total anomalous pulmonary venous return with obstruction. Pathophysiology of this group include must be presence of the obstruction to the pulmonary blood flow, and also there must be communication between the pulmonary and systemic circulation. Through it, the systemic deoxygenated blood, venous blood, shunt from the right to the left, enter to the systemic circulation by either patent ductus arteriosus, foramen ovale, ASD, and VSD. So, in this condition, in which there is cyanotic congenital heart disease with increased pulmonary blood flow, I must have two things. First of thing, obstruction to the pulmonary blood flow. ثانيا, there must be communication between the pulmonary and systemic circulation. Through it, the systemic deoxygenated venous blood shunt from the right to the left. That means from the systemic circulation, from the venous return to the oxygenated blood. So systemic deoxygenated venous blood shunt from the right to the left, enter to the systemic circulation either through the PDA, foramen ovale, ASD, and VSD. Second group, it is cyanotic congenital heart disease with increased pulmonary blood flow. These include transposition of the great arteries, single ventricle, truncus arteriosus, total anomalous pulmonary venous return without obstruction. With obstruction, and now without obstruction. Pathophysiology of this group, and now there is no obstruction of the pulmonary blood flow. And cyanosis caused by either abnormal ventricular arterial connection or from the total mixing of the systemic venous and pulmonary venous blood within the heart, as in the TGA. And now, after the classification of the congenital heart disease, we will discuss the most common types of it. Now, I will start with cyanotic congenital heart disease, and I will start with arterial septal defect. Arterial septal defect, it is account for 10% of the all congenital heart disease. It occurs in three types. Ostium secundum, which is the most common type, the hole in the region of the foramen ovale, and ostium primum, the hole located near the endocardial cushions, and it may be part of a complete atrioventricular canal defect. Now this is ostium secundum. Ostium secundum. اللي قلنا the whole, it is occurred through in the region of the foramen oval, and this is the ostium primum. Ostium primum, which is the defect. It is near to the endocardial cushion. Endocardial cushion, and maybe it is a part of the complete AV canal. Third type was sinus venosus, ASD, is the least common type, which may be associated with anomalous pulmonary venous return. Pathophysiology of the arterial septal defect. Degree طبعا قلنا هي من التايب اللي يصير ب volume load. That means communication of the blood with shifting of the blood from the left to right side. Degree of the left to right shunt, it is depend on size of the defect, relative compliance of the right and left ventricle, and relative pulmonary vascular resistance and the systemic vascular resistance. شلون هاي؟ Enlarged defect هذا ال ASD. This is the ASD. Enlarged defect. During systole, the blood, it was called by the contraction of the heart from the left atrium to the right atrium. That I mean left to right shunt. So the oxygenated blood, this is the red one, it will be entered to the mixed with the deoxygenated blood, اللي هو the blue one. Then this increase volume and the pressure load on the right atrium. And the blood will be increased through the tricuspid valve, which will result in the increase the volume and the pressure of the right atrium. And this will be result in the much higher increase in the pulmonary artery blood flow. Pulmonary artery blood flow. Okay, so this is pulmonary artery blood flow. So the ratio of the pulmonary to the systemic blood flow in semi-QP to the QS is usually between 2 to 1 and 4 to 1. 2 to 1 to 4 to 1, while in the normal condition it is 1 to 2. يعني pulmonary circulation 1 to 2 of the systemic circulation, while because of the increase of the pulmonary blood flow, the ratio QP to the QS, it will be usually between 2 to 1, sorry, and 4 to 1. Clinical features, ASD is often asymptomatic and discovered during physical examination. Even extremely large ASD, it is rarely produced clinical heart failure during childhood, but subtle failure to thrive may be present. Various degree of exercise intolerance might be present in the older children, and on examination, you will find there might be mild left precordial bulge due to the cardiomegaly by the palpation of the precordium, and right ventricle impulse can palpated on the left lower sternal border, and on auscultation, there is fixed splitting of the S2 and soft grade 1 or 2 systolic ejection murmur in the middle and upper sternal border due to the increased blood flow across the right ventricle into the pulmonary artery and not due to the low pressure flow across the ASD. The المرمر اللي سمعه اللي هو systolic ejection murmur at the middle and upper sternal border due to the increased blood flow across the right ventricle into the pulmonary artery, يعني through the tricuspid valve, and not due to the ASD. We have mid-diastolic murmur at the lower sternal border due to the increased flow across the tricuspid valve. Diagnosis by the chest X-ray, In the chest X-ray, there is cardiomegaly, right atrial enlargement, mainly right atrial enlargement, prominent pulmonary artery, main pulmonary artery, concomitant, but this is right pulmonary artery, and increased pulmonary circulation or vascularity. So these are 4 changes: cardiomegaly, right atrial enlargement, prominent pulmonary artery, main pulmonary artery and right pulmonary artery, and increased pulmonary vascularity. ECG, it will be shows right axis deviation and right ventricle. Echocardiography would be demonstrate the definitive size and location of the defect. Treatment, asymptomatic child required no treatment, and transcatheter or surgical closure indicated in all symptomatic children if they have symptoms. Asymptomatic patient with the QP to the QS ratio of 2:1 and more. That means much increase in the pulmonary vascular resistance. Severe right ventricular enlargement. Prognosis, small to moderate ASD. Infant may be closed spontaneously. Second term ASD is well tolerated during the childhood, and complications, it does not appear until the 3rd decade of the life or later, which is include pulmonary hypertension, arterial dysarrhythmia, tricuspid or mitral insufficiency, and heart failure. These are the main points about the ASD. Now I will discuss the second important ventricular septal defect, which is the most common cardiac malformations, account for about 25% of the all congenital heart disease. Types, it occurs in 3 types. The first one, which is membranous type, this is one, membranous type. It is the most common type located in the membranous portion of the septum in the posterior inferior position. This one, in the membranous, تعرفون the ventricular septum فيها both membranous portion and muscular portion. So the membranous, it is the most common type, which is located in the membranous portion. The second one, اللي هي supracrestial or subpulmonary. Supracrestial or subpulmonary. It is less common, located superior to the cresta supraventricularis, just beneath the pulmonary valve. Subpulmonary, which is located just beneath the pulmonary valve. And the third one, which is the muscular type, which is located in the mid portion of the or apical region of the ventricular septum, and it may be single or multiple, which is called Swiss cheese type. This is in the طبعا تعرفون الهارت هو upside down, so this is the what we call the apical region. This is the apical region, and this is the base. So the Swiss type or multiple muscular, which is located in the muscular part of the portion near the apical part of the septum. Pathophysiology. The onset and severity of the clinical feature depend on the magnitude of the left to right shunt, as in the ASD, which is determined by size of the VSD, pulmonary vascular to the systemic vascular resistance ratio, QP to the QS. These are 2 main determinants of the left to right shunt, اللي هو يحدد لنا the onset and severity of the clinical features. The small defect, VSD defect, It is called, which is usually less than 5 millimeter, is called pressure restrictive VSD. In other words, the right ventricular pressure is normal and higher pressure in the left ventricle, which is derived the shunt left to right, which is limited by the VSD size. يعني هنا هسه هاي ال VSD إذا كانت small زين فنسميها pressure restrictive. That means the pressure of the left ventricle it remain higher than the right ventricle, and this will be result in the limitation of the left to right shunt. And pressure هنا يكون higher. During contraction, during systole, it will be result in the left to right shunt, but will be limited in the small size of the defect. While the large defect is someone non-restricted. That means non-restrictive, in which the right and left ventricular pressure are equalized, and the direction and magnitude of the shunt is determined by the pulmonary to systemic vascular resistance ratio. هنا قلنا بالبداية لما يكون الديفكت صغير البلمونري ventricular resistance left ventricular resistance much higher left ventricular pressure much higher than the right ventricular pressure. So during the contraction of the heart, left to right shunt, which is limited by the size of the defect. So it is called a pressure restrictive. بينما إذا كان large defect between the left ventricle and right ventricle هنا the pressure gradient راح يروح لأنه راح يصير هنا يسمونه non-restrictive يعني equalization of the pressure between the right and left ventricle. So the degree of the right to left shunt now depend on the obstruction of the right arterial outflow أو pulmonary artery. هنا كل ما تكون البلمونري vascular resistance high هنا ايش راح يصير عندي؟ راح يصير عندي limitation of the left to right shunt لأن حتى لو من يصير هنا shunting of the blood from the left ventricle to the right ventricle ما راح يكون له طريق على مود يدخل لللنج فراح يصير به limitation. While if the pulmonary vascular resistance decrease, so the blood it will have its way to the lung. So the left to right shunt it will be much higher and increase the pulmonary circulation. So when the pulmonary vascular resistance begin to fall during the first 6 to 8 weeks after birth, the shunt will be increased and the clinical manifestation will appear. من ساعة قلت لكم إذا تكون هاي الفترة الpulmonary vascular resistance تظل عالية لحد عمر 6 to 8 weeks هنا يلا be decrease. The manifestation it will be occur in the VSD at the age of 6 to 8 weeks because there is decrease in the pulmonary vascular resistance and will be increased left to right shunt. When the pulmonary vascular resistance equal to the systemic vascular resistance, the shunt will become bidirectional. That means right to left and left to right, and patient become cyanosed, and what we call Eisenmenger physiology. When the pulmonary vascular resistance it is higher than systemic vascular resistance, the shunt will reverse and it will become right to left, and the cyanosis will be increased more. يصير من هذا pulmonary vascular resistance تكون higher than vascular resistance systemic vascular resistance. البريشر in the right atrium راح يكون أعلى من ال left atrium فالبلد it will be deoxygenated blood it will be directed to the left ventricle. فايش راح يصير عندي right to left shunt and the baby will become cyanosed. Clinical features: small VSD with minimal left to right shunt and normal pulmonary pressure راح يكون عندهم asymptomatic and discovered during routine examination. Characteristic: loud, harsh, hollow systolic murmur over the lower sternal border, frequently associated with the throat. And if the defect is large, with excessive pulmonary blood flow and pulmonary hypertension, the heart failure in early infancy, dyspnea, feeding difficulties, poor growth, and profuse sweating, and recurrent chest infections will be occurs. And cyanosis is usually absent, but duskiness may not during infection or the crying, and left precordium bulge and palpable parasternal lift is common. The hollow systolic murmur is less harsh than that of small VSD. لأن تعرف أنت المرمر, it is inversely related to the size of the defect. كل ما يكون الديفكت صغير كل ما يكون المرمر is louder. Mid-diastolic low pitch murmur at the apex due to the increased blood flow across the mitral valve. And the diagnosis depends on the chest X-ray. It shows in the small VSD, it is usually normal, while in the large VSD will be demonstrate cardiomegaly, and increase in the pulmonary vascularity. Cardiomegaly and increase in the pulmonary vascularity. ECG will be normal in the small ASD, small VSD, and large. In the large VSD, there is biventricular hypertrophy with notched or peaked P wave, and echocardiography, it is give us the definitive diagnosis by determination the size and location of the defect, direction and magnitude of the shunt, and measurement of the pulmonary pressure. Natural course or natural history of the VSD, it is depend on the size of the VSD. 30 to 50% of the small VSD closes spontaneously, mostly during the first 2 years of life. And the small muscular VSD are more likely to close up to 80% than membranous VSD, up to 35%. And the closed VSD often have ventricular septal aneurysm, which limit the shunt magnitude. Most children with a small restricted VSD remain asymptomatic, and non-operated VSD might increase incidence of arrhythmia, subaortic stenosis, and exercise intolerance. Treatment: prophylactic antibiotic to prevent subacute bacterial endocarditis, which we will discuss later in the lecture of the subacute bacterial endocarditis. Treatment of the heart failure in the large VSD by diuretics and digoxin, as we will discuss in the lecture of the heart failure. And surgical closure will be indicated in continued poor growth or pulmonary hypertension and despite medical treatment. That's all about the ASD and VSD. And thank you so much for your kind attention. And please, if you have any question, contact me with my pleasure. Thank you very much.